Good afternoon, ladies and gentlemen. I am Dr. Ferdy Alcala, your moderator, and together with the session's chair and co-chair, Dr. Maricel Gler and Catherine Yu, we welcome you to the annual Dr. Antonio Gonzaga Memorial Research Forum. Dr. Antonio J. Gonzaga was one of the pillars of research and training in infectious diseases in the Philippines. He was a constant source of encouragement and support for young infectious disease fellows. He pioneered the creation of the University of the Philippines Philippine General Hospital Tuberculosis Study Group and the establishment of the TB Research Laboratory of the Philippine General Hospital Medical Research Laboratory, which generated relevant quality researches. The Dr. Antonio Gonzaga Memorial Research Award has been created to celebrate and honor Dr. Gonzaga's research achievements in the field of infectious diseases. The Dr. Antonio Gonzaga Memorial Research Award is bestowed annually to the principal author of a completed research project in the field of infectious diseases, judged to be both of high methodological quality and relevant to the health problems of the country. To formally open the session, we call on Dr. Catherine Yu for her welcome remarks.
So good afternoon. I'm Dr. Catherine Yu. I will be your co-chair, and I would like to welcome you all to the Dr. Antonio Gonzaga Memorial Research Forum. This forum will showcase the products of hard work of our trainees, both in residency and in fellowship, and also from our peers in the field. And this year we have received over 40 research papers, and these have been shortlisted for the oral presentation. So without further ado, let me turn over you to Dr. Gler, the chairperson of the Committee of Research, to tell us about the research paper mechanics.
For the mechanics of this research presentation, so all abstracts were submitted either online and by email, and these were prejudged by 8 PSMID research committee members. So we have received 54 abstracts for this year, and 44 were prejudged by the 8 research committee members, and of this 44, the top 10 or top 5 of the descriptive and top 5 of the analytical category were chosen for oral presentation, which we will be presented this afternoon. Next. So each research output should be authored by a resident or fellow in training in a PCP or PSMID accredited institution. The study protocol must have gone through their rigorous technical and ethical review by the institutional review boards of their respective institutions. Next. To the next slide, please. So the judging, there's another slide. The judging would comprise of pre-judge scoring. My slide before that. Okay, sige. Pre-judge scoring before that. The slide before this would be the pre-judging scoring, which comprises of, okay lang, memorize ko naman. It's comprised of the research title, which should be a total of 5. The research, the abstract would be 5. The intro, review of related literature is 5. Methodology would be 20. And the results 20, and the discussion would be 20. So this would be a total of 80. And then for this afternoon, they will just be, and these have been pre-scored already. So, and this afternoon, we will just the judges will just score them on the presentation. Next. So this would be the scoring for the presentation: visual aid 5, delivery 5, and grasp in the question and answer 10. Next. So each presenter was given 6 minutes to do their presentation. This is pre-recorded, and you will have 3 to 5 minutes of answers of questions and answer, and by the judges. And any presentation extended beyond the allotted time will be given a 10 points deduction from the presentation score. That's it for the presentation. Ferdy? I will. Ferdy, you're on mute.
Okay. To introduce our judges, may we call back Dr. Catherine Yu for the introduction of our judges.
Okay, thank you, Ferdy. So can we have the slides for our judges?
Slides of the judges.
Okay, so to introduce our panel of judges, our first judge serves currently as the Ethics Review Committee member of the Food and Nutrition Research Institute, Department of Science and Technology, is a faculty member of the Ateneo Graduate School of Business Ateneo de Manila University, and has received her Bachelor of Science in Public Health in UP Manila, also received her master's degree in science in epidemiology in UP Manila in 2006, and also received a doctoral program in health and sciences from the Tampere University, Tampere, Finland. Let's all welcome Dr. Pauline Jean Claro. Our next judge would be Dr. Rosary Ann Reyes. She's currently working at INC Research Philippines as the project manager, is a freelance consultant of epidemiology and biostatistics, and worked at the Parexel as a clinical research associate and Otsuka Pharmaceuticals as a clinical trial lead. She receives her bachelor's degree in public health from the University of the Philippines and a master's degree in public health epidemiology from the UP Manila, and successfully achieved the Academy of Clinical Research Professionals Certified Clinical Research Associate CCRA designation. And so welcome Mary Rosary Ann Reyes. And our third and last judge for today has received her Doctor of Philosophy, graduate of School of Medical Sciences, Kyushu University, Master of Medical Science, Graduate School of Medical Sciences, Kyushu University, is a research student at Graduate School of Medical Sciences, Department of Bacteriology from the same university, and is also an international, a Japanese language intensive course, International Student Center of the Kyushu University. She also received her Master of Public Health from the College of Public Health, University of the Philippines, and a Bachelor of Science in Public Health from the same university. Let's all welcome Sharon Yvette Villanueva. And so we go back to our host, Kate, Ferdy.
Thank you, Dr. Yu. We now start the ball rolling. So we start with the descriptive category. And we may now call on Dr. Anime L. De La Cruz from Makati Medical Center with her research, Adult Influenza, and pneumococcal vaccination assessment of physician and patient barriers.
Adult influenza and pneumococcal vaccination, an assessment of physician and patient barriers in Makati Medical Center. One of the most common organisms that can cause severe disease in one population is influenza. Streptococcus pneumoniae is also an etiologic cause of community-acquired pneumonia. Both disease morbidity and mortality are increasing annually, and most commonly affected are the elderly. Locally, healthcare cost is increasing for CAP high risk, and seasonal influenza also contribute to the economic burden. Research said additive benefits are noted on both morbidity and mortality to patients receiving both vaccine. But despite efforts, CDC still reported a significant percentage of unvaccinated adults. With this problem in mind, our general objective in this research is to know the current knowledge and attitude towards influenza and pneumococcal vaccinations of both physicians and target patients. Our specific objective is as follows. Study design used was prospective cross-sectional analytics study, and our survey questionnaire was designed by Adelphi Research. For Group A, all physicians under the Department of Internal Medicine in Makati Medical Center were eligible. Sample size was 185 subjects. 10 physicians were excluded. Proportional allocation was done to determine the number of fellows, residents, and consultants. And for this group, stratified random sampling method was utilized. Once consent was secured, interview was done, data was gathered and analyzed. This study utilized convenient sampling method for Group B. Computed sample size of 218. Patients permitted by their physician, both from in and outpatient department, are eligible. Inclusion criteria were Filipino, male or female, age 65 years old and above, or 19 to 64 years old with certain medical condition classified by CDC as high risk. There were no excluded participants from this group. Once consent was secured, interview was done. Again, data was gathered and analyzed. For the results of Group A, among the 185 physicians, majority are consultants, all of which came from different subspecialties. Majority of the healthcare providers believe that the elderly and the indications stated by CDC should be given pneumococcal vaccination, as well as influenza vaccinations. For physicians' perceived barriers for pneumococcal vaccine, one of the most common reasons was the patients fail to visit their clinics regularly, which was also related to other common answers such as poor knowledge and concerns regarding side effects. Other physicians also see cost as a barrier as well. For influenza vaccine, physicians' answers were almost similar. For the result of Group B, majority of the respondents were female, 36% of which are admitted in MMC. All patients have wide variation of diagnosis. More than half of the respondents, at 59.6%, were unvaccinated, in comparison to only 26.6% who received both. The most consistent reason for not receiving the vaccine is the inability of their physician to educate them, which is also supported by other respondents that they don't know when to get it. Recent events and report alleged complications of vaccine gave these consumers reason to avoid it. Costs were also a concern for some. Same with pneumococcal vaccination. Most common reason of not receiving the shots of influenza is due to inability of their physician to inform them as well. Cost is also one of the reasons. Comparing the barriers between vaccines, respondents significantly are worrisome that they may get influenza after the shot. For pneumococcal vaccine, patients are less educated regarding its schedule and noted that it's more expensive. Lack of consensus of physicians' knowledge regarding which groups of adults are indicated for vaccination could also be a barrier. Further studies to measure doctors' knowledge as well as formulation of intervention may improve rates. Initiating awareness is important, but there should also be cooperation and consent from the patient. The healthcare workers play a significant part in a vaccination program and should be compliant and consistent in recommending these medications. In one study, both physicians as well as the patients highlighted that cost is a concern regarding its compliance. Both groups noted that insurance coverage may have a positive effect on rates. Numerous research proposed educational intervention to improve vaccination rates, one of which is the reminder or recall systems. We also coined the term vaccine hesitancy, wherein procrastination in administration or rejection on the part of the patient of vaccine despite the availability of services, with the most common reason or concern is safety. It may be due to circulating media reports and highlighting a rare negative adverse event to a vaccine may result in negative impact not only to one vaccine but also to all. In conclusion, most common barriers on both physician and patients were secondary to lack of education. Persistent reminder and follow-up may improve compliance rates. Thank you.
Do we have some questions and or clarifications from our judges to our presenter?
Yes, thank you, Doc. Hi. Uh, Thank you for that presentation. So I reviewed your paper, and in the review of literature, I noticed that most data that you presented are from overseas. So I think it would be good to provide information on Philippine data or current status of pneumococcal or influenza vaccine in the local setting. So you could include information whether your institution has current program on this vaccine, and also if there's a national program for this vaccine, so that when we look at your outcome, especially these are barriers, we'll be able to identify possible recommendations on how they could also improve on that. With regards to my question, I noticed that the questionnaire, it was designed and conducted by Adelphi Research by design. So is that used for the US study?
Yes po, US and was also yes, from the US po, not here in the Philippines.
Yes, and was that validated taking into consideration the population that you're going to use that questionnaire?
It
I
was
mean,
also validated by Nicole et al. It was also in the references, but again, it's done here in the Philippines.
not validated taking into consideration the Philippine culture and
It was
the
validated
setting,
po.
the
It was
local setting.
validated by Nicole et al. But not here in the Philippines po.
Yes, so it was validated for use in the US. So the reason I'm asking, because of course there would be differences in culture between the US and also the respondents in the US where that questionnaire has been used. So for future studies, if questionnaires will be used, it would be, I highly recommend or to take into consideration to validate the data collection instrument to assess its dependability and also to ensure, of course, that the data collected is reliable. So similar to when you collect blood pressure, that you calibrate those data collection instrument. Of course, the questionnaire you cannot calibrate, so you only need to validate. And I also noticed that you translate it to Filipino. So it's not like the ICF that you can translate forward and backward, but it also needs to be, there's such thing as linguistic validation, wherein that would ensure that the questionnaire is understood in the same way. It would be understood by everyone that who would complete it, the same way. So,
Noted.
yeah,
Thank you.
thank you.
Thank you po.
Thank you very much. So let's now proceed with our second descriptive study from Philippine General Hospital. Dr. Jonelle B. Poblete with her study Genetic Diversity of Mycobacterium Tuberculosis Isolates from a Rural Community in the Philippines.
I'm Janelle Poblete from the Department of Medicine, UP-PGH, and this is our study, the genetic diversity of Mycobacterium tuberculosis isolates from our rural community in the Philippines. TB remains a public health problem affecting millions of people each year, and the Philippines has one of the highest number of new TB and drug-resistant cases worldwide. Despite its prevalence, there is limited genomic data for our local MTB strains. A previous study in Metro Manila found that TB isolates belong to a distinct class called the EAI2 Manila or the Manila strain. Manila strain was also found to be predominant in Santa Rosa, Laguna, a suburban community. Currently, data on the genetic diversity of MTB isolates from rural communities in the Philippines remains sparse. Hence, we aim to determine the prevalent MTB genotype in San Juan, Batangas, our rural and coastal community in Luzon, and analyze the factors associated with genotype and clustering of MTB isolates. Culture-positive isolates from Filipino patients aged 15 and above from a prospective community-based TB prevalence survey conducted in San Juan, Batangas from May 2013 to July 2015 were included. Out of 210 culture-confirmed isolates, only 125 isolates yielded adequate genomic DNA for further molecular analysis. All 125 isolates were genotyped using spoligotyping and 15 loci mirror VNTR. Cluster analysis was performed to determine the proportion of TB cases due to recent transmission. Of the 125 culture-positive isolates that underwent molecular analysis, 80% were from male patients and 87% belonged to the economically productive age group. Majority were obtained from smear-positive cases and have low bacillary load, defined as having less than or equal to AFB2+ or positive only in culture. Drug susceptibility tests were respectively obtained and showed that around 26% had resistance to any anti-TB medication. 27 isolates were monoresistant to either first or second-line drug, 1 was MDR-TB, and another 4 were resistant to at least 2 non-MDR anti-TB meds. Spoligotyping yielded 34 distinct spoligotype patterns. We discovered 15 new spoligotype patterns that were not previously reported in the database. 19 patterns were previously reported, and 3 out of the 19 spoligotype patterns had no corresponding genotype. So this is the genotype distribution based on spoligotyping, where EAI2 Manila predominates. 15 loci mirror VNTR showed a better discriminatory power than spoligotyping alone. 2 out of the 3 isolates identified with spoligotyping as EAI5 were found to be EAI2 Manila, and all unidentified strains based on spoligotyping were found to be EAI2 Manila based on 15 loci mirror VNTR. Combining the 2 classical genotyping tools showed that the Manila strain is the predominant MTB genotype in San Juan, followed by EAI5, Beijing, and LAM2. So this distribution is consistent with previous molecular studies done in the urban and suburban communities in the Philippines. Only 3 isolates belong to different genotypes, and this may represent imported transmission. Genotype was also statistically associated with sex and resistance to rifampicin and streptomycin. Clustering rate was used as an index of recent transmission in the study. Compared to the observed clustering rate in Santa Rosa, Laguna, a suburban community in the Philippines, the clustering rate in San Juan, Batangas was slightly lower at 26.4%. And the difference in clustering rate among the 2 communities may be explained by the difference in the degree of urbanization between the 2 communities. Urbanization could result in higher population densities, more crowded living conditions, and increased mobility among migrants seeking temporary work that could promote TB transmission. Majority of the clustered isolates were from male patients, 15 to 49 years old, smear-positive cases, and those with low bacillary load. However, significant association was only present for age and smear positivity. So younger patients usually have more close contacts than older patients, hence increasing the risk of transmission. The presence of acid-fast bacilli in the sputum may also correlate with the infectiousness of TB, hence increasing the transmission. Since samples were obtained from symptomatic adults with cough of at least 2 weeks, the frequency and vigor of coughing may also contribute to the transmission of TB, especially in a community setting where there's closer proximity and longer duration of contact between the different patients. No association was found between clustering and drug resistance. So this study has several limitations. It only provides a small molecular snapshot of the predominant circulating MPV genotype in the country. So large-scale multi-region studies must be performed in the Philippines. Classical genotyping techniques such as MIRO-V and PR and spoligotyping also have lower discriminatory power compared to newer technologies such as the whole genome sequencing, especially for the Manila strain that has been shown to have very low genetic variability. It's also possible that the lower discriminatory power of these genotyping tools could overestimate the number of clustered isolates in the study. Clustering in geographically stable populations such as the San Juan Batangas may also result from simultaneous reactivation of a latent infection acquired from the same source in the past and may not represent recent transmission. So ideally, investigation of clusters should be done through contact tracing in order to determine if there is true transmission link that exists between the clustered isolates seen in the community. In conclusion, this study provides important baseline data on the predominance of the Manila strain in a rural community in the Philippines. Lower clustering was observed in this community compared to Santa Rosa, Laguna. Younger patients and those with smear-positive samples were also more likely to form a cluster. Thank you and have a nice day.
Thank you, Dr. Poblete. Judges, are presenters now ready for your comments and questions?
Okay, thank you for that good study. Okay, so this is an example of a descriptive study that is very rich in information, and I like it because it's one, it sets the future, for foundation for future studies, and there are lots of hypotheses that we can actually build on this. Okay, so but I just want, before I ask the questions, I just want to give some comments. No? I just find in the paper and also in the presentation today, I just find background rather limited. No? So I think it would benefit from being described more, by being expounded more. No? So for since you are looking at genetic diversity, what is actually the status globally? How many strains we are looking at? And then you mentioned, because you already focused specifically on the Philippines, so it must be ideal if we went from general to specific before. So and then I also think there's another local study that you should use or include in your references, because it's by Phelan, the author is Phelan, and other colleagues, and I think also collaboration with international colleagues, because they found the same strain that you found in your study. Okay, so just some comments. And now for my questions. So since I'm an ethics review committee member, I want to ask if you were able to get consent from the patients to use their data, because you only reported that it was given ethical clearance. No? But we want to highlight this in papers also. Doc?
For the TB surveillance, hello ma'am. Good afternoon. For the molecular study, ma'am, since this was done retrospectively and based on archives isolates alone, so we weren't able to get individual consent from the patients since this study was done retrospectively.
Yeah, but the initial, because you said the information was collected from an existing survey, right? So
yes.
Did that survey actually? This is an example of us ensuring that when you get consent from the patients, it's like getting a blanket concern that other studies, future studies, other data mining that will be done. So please include that in your paper.
Yes.
Okay. Then I just want to ask, because you did not also specify the objectives, but because initially I thought it was purely descriptive, but now you had explored some associations. That's why you reported this differences. So please also state that also. I think you were looking at association in terms of clustering, right? So
yes, ma'am.
Okay. Yeah, so also some notes, please specify that what you reported were actually crude associations. No? So there was
Yes,
no
ma'am.
control for confounding and other risk factors. So maybe it can be mentioned as a limitation of the
Yes,
study.
ma'am.
Since you recommended that there would be more large-scale studies to be done in the future for us to do this in other communities, what would be the economic implications of this?
Well, right now, since most of the molecular tools that we're currently utilizing in terms of genotyping TB require specific laboratories with specific needs. So currently with our since the Philippines is a relatively low resource setting, it might be difficult to apply this. But newer molecular tools right now, such as whole genome sequencing, are currently being utilized by developed countries, specifically in looking at the different molecular barcodes, determining SNPs, relationship of the different genotypes with molecular resistance, with the drug resistance profile. So I'm thinking eventually in the future, when we have enough resources to utilize both clinical epidemiology tools and molecular epidemiology tools, we will be able to study efficiently the transmission dynamics of TB in multiple communities in the Philippines.
Thank you.
Thank you, Dr. Poblete, and thank you, Judge, for that wonderful comment. Let's now proceed with the next study from Makati Medical Center, to be presented by Dr. Christy Michelle Taladua, entitled Presenting Characteristics, Comorbidities, and Predictors of Mortality Among 236 Patients with COVID-19. Dr. Taladua.
Good day, everyone. I am Maria Teresa Santos, Infectious Disease Fellow of Makati Medical Center. Together with my co-fellows, Dr. Annalyn Homeras and Dr. Christy Michelle Taladua, we will be presenting to you our paper entitled Presenting Characteristics, Comorbidities, and Predictors of Mortality Among 236 Patients with COVID-19. There is limited information on the demographics, clinical characteristics, and outcomes of patients admitted for COVID-19 in the Philippines. Makati Medical Center reports its first confirmed case of COVID-19 last March 8, and thenceforth there has been a growing number of cases being managed in the institution. This is to describe baseline characteristics of all RT-PCR positive patients and to determine factors associated with mortality or survival. This is an observational, single-centered study which include all confirmed COVID-19 patients admitted at Makati Medical Center, Philippines, between March and April 2020. Cases analyzed were confirmed severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2 infection by positive result on real-time polymerase chain reaction RT-PCR testing. Patients who were clinically diagnosed and managed as COVID-19 but with negative RT-PCR were not included. Data collected included patient demographics, symptoms on onset, comorbidities, vital signs at baseline, classification of disease severity on admission and upon discharge, initial laboratory tests and radiographic findings, treatments and outcomes. Date of first onset of symptoms was noted for all patients and corresponds to time 0 for days of illness. Disease severity is based on WHO classification. Patients were grouped into survivors or non-survivors, and variables between groups were compared. Throughout the analysis, the level of significance is set at 0.05. We have a total of 236 patients. 210 or 89% were discharged, 24 or 10.2% died, and 2 or 0.9% are still admitted at the time of the analysis. Patients have a mean age of 52, with an older trend among non-survivors. However, this was not statistically significant. Majority of the patients were male, and gender was strongly associated with mortality. Only 31% of the cases had a known exposure to COVID-19 case. Initial reports noted that COVID-19 infection can cause more adverse consequences, including deaths to persons who have pre-existing diseases. 79% of the 236 patients have comorbidities. The most common conditions were hypertension, diabetes, and lung disease. Among these, hypertension, kidney disease, and lung disease were strongly associated with mortality. Most common symptoms presented by the patients were fever, cough, and shortness of breath. Shortness of breath is significantly associated with mortality, having a risk of 8 times higher among those who did not have the symptom. More than half of the patients have moderate disease at presentation. 12% were severe and 17% were critical. Of the 236 patients, 18% have normal chest X-ray, and majority or 60% of them have bilateral pneumonia. Hematologic profile of patients show that non-survivors have a mean WBC of 11.36, which is slightly elevated than normal. It is also higher compared to the survivor group. Significant lymphopenia was observed among non-survivors with significant association with mortality. The next slides are figures showing trends of inflammatory markers based on disease severity and mean values among and between two groups. CRP levels were observed to be higher among severe and critical patients, and values start to decrease on the 7th day of admission with appropriate intervention. Non-survivors have a significantly higher mean CRP level compared to survivors, with a p-value of 0.03. For severe and critical cases, lactate dehydrogenase levels were observed to be elevated throughout hospital course. Non-survivors were also noted to have a higher mean value of LDH compared to survivors. Serum ferritin levels were elevated in almost all of the patients, with a mean of 10 times higher than normal among non-survivors. Mean procalcitonin level of non-survivor group is higher compared to survivor group, with no significant difference between the two means. D-dimer is a significant factor for mortality. Non-survivors has a higher mean compared to survivors. 55% of the patients didn't have oxygen supplementation at baseline, and 7.6% were already intubated on admission.
This bar graph shows the antimicrobial prescription among survivors versus non-survivors. The most prescribed antibiotic is azithromycin, usually given together with either ceftriaxone or piperacillin tazobactam. The third most prescribed antibiotic is cefepime, followed by meropenem. 14% did not receive any antibiotic at the onset. Of the 236 admitted patients, only 2 yielded positive blood cultures, and 18 have growth on sputum cultures. This should be noted that majority of these growths were not at baseline, but already at the latter course of the disease. A total of 42 patients were given tocilizumab. For those who received 2 doses, all moderate to severe cases survived, while only 50% of the critical survived. A total of 171 patients were given antimalarial drugs. There is no significant difference between the two groups who received chloroquine or hydroxychloroquine. 65 patients received lopinavir/ritonavir. 24% who were given the drug survived, while more than 50% died. Giving of steroids was only considered on the latter part of this pandemic. Only 15 of the 236 patients received steroids. 4.7% of them survived, while 20% of the non-survivors who were given steroid died. Furthermore, we analyzed moderate COVID-19 patients who received chloroquine. Of the 67 moderate COVID-19 patients who were given chloroquine alone, 7.5% progressed to severe or critical. All of them survived. 4 of the 67 patients while on chloroquine progressed to critical disease, and they received tocilizumab. 1 died. A total of 41 patients were admitted in the ICU. 46 were intubated, and 22 underwent CRRT or hemoperfusion, with at least more than 50% who were survivors. This graph shows the mean with standard deviation of timeline for different variables for 2 groups. For the survivors, ICU admission comes as early as the 4th day and as late as up to the 17th day of illness. They are shifted to a high-flow nasal cannula as early 5th day and as late as up to the 15th day of illness. Tocilizumab is given as early as the 6th day and up to the 12th day of illness. Earliest discharge is on the 12th day of illness, while some get discharged on the 28th day of illness. For the non-survivors, ICU admission ranges from the 6th day to the 16th day of illness. They are shifted to high-flow nasal cannula earliest on the 6th day of illness. Day of intubation and tocilizumab is the same as the non-survivors, earliest on the 6th day of illness. Of note, steroids were started out late, usually at the 10th day of admission. This may be one of the reasons why there was a significant difference between the use of steroids in survivors and non-survivors. It may be that those who are non-survivors received the steroid a bit late compared to the survivors. Death in non-survivors is earliest on the 9th day of illness. Thank you for listening.
Thank you, Dr. Taladua. Again, may we remind our judges and the presenter that we only have 3 minutes for the question, comments, and answers. Judges, do you have any questions for our presenter?
Good afternoon. Thank you very much, Dr. Taladua and your group mates for the very timely and very informative study on COVID-19. My first comment is similar to the previous group. I was also looking into just a statement on the ethical considerations since you collected or you examined the charts of your patients. So I was looking at first the approval from the Ethics Review Board of Makati Medical Center and also the approval of the administration for you to examine the charts or review the charts of the patients, and also were the patient charts de-identified or anonymized. Yes, Dr. Taladua.
Hello po. Good afternoon po. Good afternoon po sa lahat. For this one po, Doctor, we did not ask for a consent from the patients because it was also a retrospective study. So we just perused through their charts po, and then we looked at the results and the tests that were done with these patients that we have po. So we were able to get any consent from these patients.
Not really from the patients, but even from the administration, or is there a rule in Makati? Anyway, let me go to the questions. My question. I was just a little bit confused with your use of the baseline because what do you mean by baseline in your study? Does it mean baseline from the start of the disease until the disease progressed, or is it baseline because this is the first time that the study was done?
Baseline because it was during the admission of the patient when these tests were taken. So that was our baseline. So it's on the first hospital day of the patient.
And so I'll follow through with the baseline because I would like to suggest, since in your tables you put baseline data and then the survivor and non-survival of your patients, maybe it would also be better if, I don't know if you did this, but did you make continuous, or did you study the different markers throughout the stay, the hospitalization of the patients?
Yes, we did.
Go ahead, Dr. Taladua.
We did review po, but it was already not part of the study that we did because we only wanted to make the baseline characteristics. Regarding the trend of the markers, we also did it, but for us, it cannot be included in the study anymore because it's too broad. but we do have data on the trend of these markers.
Thank you, Dr.
Thank you.
Teladua. We now proceed with our next paper, which is also on COVID. Our next presenter is from San Lazaro Hospital. May we call on Dr. Maria Luisa R. Maranan with her paper, Clinical Features and Outcomes of HIV Patients with COVID-19 in a Tertiary Infectious Disease Referral Hospital in Manila, a case series.
Good day. I'm Maria Luisa Maranan, and I'll be presenting a key series entitled Clinical Features and Outcomes of HIV Patients with COVID-19 in a Tertiary ID Referral Hospital. Globally, COVID-19 has caused significant mortality and morbidity. The Philippines still reports of sustained community transmission. The Philippines is also challenged with rising cases of HIV, to which our country has the fastest growing incidence in the Asia Pacific. Among people with HIV, TB co-infection is also a problem in the Philippines. Recent studies, it was concluded that HIV-positive patients with SARS-CoV-2 infection are not at greater risk of severe disease or death than HIV-negative patients. However, the majority of these reported cases were on ARV therapy and suppressed viral load. Data are still limited for those ART-naive HIV positives with low CD4 and unsuppressed viremia. As of June 2020, 4% of our admitted COVID-19 confirmed patients were HIV positives. All were males and their median age is 25 years. All 5 have TB co-infection. Majority are ART naive. CD4 count on admission range from 2 to 189. Only 1 patient had ARV regimen months prior admission and he showed suppressed viremia. 2 other patients showed high viral load. Fever was the most common symptom among all patients, followed by cough and dyspnea. These were the admission criteria for COVID-19 suspects. 2 patients have CNS manifestations. 1 presented with sensorial changes, while the other presented with both sensorial changes and lateralizing weakness. COVID-19 was confirmed by positive SARS-CoV-2 RNA via RT-PCR test from OPS and PS samples. All patients had CT values of 40 and below and were considered positive. Median onset of symptoms to RT-PCR positivity is 4 days. X-ray of patient 2 showed no abnormalities, but his CT scan revealed multiple nodules with cavities and bilateral ground glass opacities in distributed fashion. Except for patient number 5, who had no chest CT scan, 4 other cases presented with multiple bilateral ground glass opacities with sporadic distribution. TB-related lesions were mostly noted. All 5 patients also had concomitant OIs as shown in the table. 1 patient also developed bacteremia with ESBL Tarcela and Abau-Mandi on sputum culture. CBC showed anemia, neutrophilia, and lymphopenia in all patients. Only 1 showed leukocytosis. ABG results showed no hypoxia, but all showed respiratory alkalosis. Patients 3 and 5 showed low ROX index suggestive of impending respiratory failure. Same patients presented with both respiratory and CNS symptoms. Both started on IV antibiotic and steroids. Head CT scan of patient 3 showed hydrocephalus, while a one-sided mass with mass effect was seen in CT of patient 5. LP was done only in patient 3. CSF analysis consistent with bacterial meningitis. Hydrocephalus points to diagnosis of TB meningitis, hence a dual CNS infection was considered for patient 3. Head CT of patient 5 is indicative of toxoplasmosis. He had the highest viral load and had sensorial changes upon admission, giving him a poor prognosis. Both 3 and 5 expired after 72 hours. The remaining 3 showed respiratory symptoms. Patient 2 was given steroids for Stevens-Johnson's, while ARV was delayed after resolution of SJS. Patient 1 and 4 were given protease inhibitors in accordance with the initial PSMID guidelines. Patient 1 was intubated because of desaturation and later died because of respiratory failure and CNS infection. Patient 2 with CD4 of 2 and a high viral load was alive, eventually expired after 41 days of confinement. Patient 4 with a high CD4 was the only one who survived and was discharged with ARV and anti-TB meds. 2 patients was documented to have the longest days of viral shedding, which was measured from the onset of symptoms up to the last positive result of RT-PCR. Looking at the CT value of these patients, there was prolonged shedding towards the 24th to 35th day of illness, coinciding with occurrence of HAP and bacteremia. For patient 4, he eventually became asymptomatic and was discharged after 14 days. PTB was the only co-infection in this patient. In our case series, we report 60% mortality, which was associated with low CD4 count. Contrary to the other reports, there are no major difference in COVID-19 course and outcomes among HIV-positive patients because their subjects are on effective ARV. An inverse relationship between CD4 count and mortality rate among SARS-CoV-2 and HIV co-infection were noted in other reports. This is comparable with our results, where non-survivors had low CD4 cell count while the patient with higher CD4 values survived. Progressive decline in CD4 count among TB HIV co-infection explains increase in susceptibility to COVID-19. This is comparable with our paper. Impaired consciousness was observed in 2 of our patients and was reported in 37% of patients in a study by Mao. CNS OIs in HIV carry a poor prognosis. Our patient showed prolonged viral shedding, consistent with reports of ZAO that shedding can at admission range from 2 to 189. Only one patient had ARV regimen months prior admission, and he showed suppressed viremia. 2 other patients showed high viral load. Fever was the most common symptom among all patients, followed by cough and dyspnea. These were the admission criteria for COVID-19 suspects. 2 patients have CNS manifestations. One presented with sensorial changes, while the other presented with both sensorial changes and lateralizing weakness. COVID-19 was confirmed by positive SARS-CoV-2 RNA via RT-PCR test from OPS and PSAB samples. All patients had CT values of 40 and below and were considered positive. Median onset of symptoms to RT-PCR positivity is 4 days. X-ray of patient 2 showed no abnormalities, but his CT scan revealed multiple nodules with cavities and bilateral ground glass opacities in distributed fashion. Except for patient number 5, who had no chest CT scan, 4 other cases presented with multiple bilateral ground glass opacities with sporadic distribution. TB-related lesions were mostly noted. All 5 patients also had concomitant OIs as shown in the table. One patient also developed bacteremia with ESBL Klebsiella and Abaumanni on sputum culture. CBC showed anemia, neutrophilia, and lymphopenia in all patients. Only one showed leukocytosis. ABG results showed no hypoxia, but all showed respiratory alkalosis. Patients 3 and 5 showed low ROX index suggestive of impending respiratory failure. Same patients presented with both respiratory and CNS symptoms. Both started on IV antibiotic and steroids. Head CT scan of patient 3 showed hydrocephalus, while a one-sided mass with mass effect was seen in CT of patient 5. LP was done only in patient 3. CSF analysis consistent with bacterial meningitis. Hydrocephalus points to diagnosis of TB meningitis, hence a dual CNS infection was considered for patient 3. Head CT of patient 5 is indicative of toxoplasmosis. He had the highest viral load and had sensorial changes upon admission, giving him a poor prognosis. Both 3 and 5 expired after 72 hours. The remaining 3 showed respiratory symptoms. Patient 2 was given steroids for Stevens-Johnson's, while ARV was delayed after resolution of SJS. Patient 1 and 4 were given protease inhibitors in accordance with the initial PSMID guidelines. Patient 1 was intubated because of desaturation and later died because of respiratory failure and CNS infection. Patient 2 with CD4 of 2 and a high viral load was alive, eventually expired after 41 days of confinement. Patient 4 with the high CD4 was the only one who survived and was discharged with ARV and anti-TB meds. 2 patients was documented to have the longest days of viral shedding, which was measured from the onset of symptoms up to the last positive result of RT-PCR. Looking at the CT value of these patients, there was prolonged shedding towards the 24th to 35th day of illness, coinciding with occurrence of HAP and bacteremia. For patient 4, he eventually became asymptomatic and was discharged after 14 days. PTB was the only co-infection in this patient. In our case series, we report 60% mortality, which was associated with low CD4 count. Contrary to the other reports, there are no major difference in COVID-19 course and outcomes among HIV-positive patients because their subjects are on effective ARV. An inverse relationship between CD4 count and mortality rate among SARS-CoV-2 and HIV co-infection were noted in other reports. This is comparable with our results, where non-survivors had low CD4 cell count while the patient with higher CD4 values survived. Progressive decline in CD4 count among TB-HIV co-infection explains increase in susceptibility to COVID-19. This is comparable with our paper. Impaired consciousness was observed in 2 of our patients and was reported in 37% of patients in a study by Mao, saying as OIs in HIV carry a poor prognosis. Our patient showed prolonged viral shedding, consistent with reports of ZOO that shedding can last up to 37 days among HIV. Mild cases of COVID-19 have early viral clearance, with severe cases have longer days of clearance. In conclusion, COVID-19 outcomes are significantly affected by pre-existing comorbidities and presence of OIs with low CD4 count. High viral load and delayed clearance of SARS-CoV-2 will result to a prolonged hospital stay and confer risk of high among immunocompromised. These are my references. Thank you.
Thank you, Dr. Maranan. Judges, do we have comments or questions?
Yeah, hi, good afternoon. So thank you again for that presentation. So in your paper, you mentioned the unique characteristics of HIV patients with COVID-19. However, I find the paper to be limited in terms of describing comparison between the clinical presentation of those HIV patients with COVID-19 versus that of HIV negative. So in order, not all of your readers would be, or not all of your readers are experts on in HIV, so they are not very familiar with the HIV presentations of HIV negative patients. So it would be good if you include that in your paper so that we'll have more, appreciation when you say that these are unique characteristics. So what makes them unique? And then for my question, I noticed that you presented the baseline laboratory and imaging results, these biomarkers, and also the clinical presentations. You've discussed them well in the paper, but I just noticed that the measurements and clinical presentations on the follow-up stage before the outcome and the follow-up stage, I did not find that in the paper. Is there a particular reason why it was not included? Because I'm thinking that I will have a clearer picture if the clinical presentation from admission, during treatment, and then post-treatment. So I was kind of looking at that way. But we have that information. If we do not have time, I just suggest that you include that in the paper.
Most of since the paper was written around June, so we were able to, most of the description were mainly when it was done during admission. So it was, we were not able to follow up with especially for the last patient who who survived. It was not.
Okay.
Okay.
Thank you.
Thank you, Dr. Maranan. Okay, for our next presenter, okay, he's a comebacker. Okay, from the Philippine General Hospital, again, may we call on Dr. Jonel B. Poblete for his paper, Clinical Profile and Outcomes of Patients with Tuberculosis, Tuberculous Arthritis admitted in a tertiary hospital in the Philippines.
I'm Jonel Poblete from the Department of Medicine, UP-PGH, and on behalf of our team, I will be presenting our study, the clinical profile and outcomes of patients with tuberculous arthritis admitted in a tertiary hospital in the Philippines. The Philippines belongs to the top 30 countries with the highest TB burden in the world. TB arthritis is a relatively rare extrapulmonary manifestation of TB that can cause significant joint damage leading to permanent disability. In the absence of MTB and the synovial fluid, TB arthritis may be difficult to diagnose based on clinical grounds alone. Hence, this may lead to incorrect initial diagnosis and cause a delay in treatment. Currently, there is paucity of data on the clinical picture of TB arthritis in the Philippines. Hence, This study aims to describe the clinical profile and outcomes of TB arthritis patients admitted in the Philippine General Hospital. Patients above 18 years admitted in PGH from 2006 to 2019 were included in the study. A diagnosis of TB arthritis was made using any of the following: isolation of TB from joints by microscopy, culture, or PCR, evidence of cascadating granuloma and biopsy, or based on combined clinical presentation, radiographic findings, and response to anticox. 65 adult patients were included in the study. Majority were male with a mean age on diagnosis of 47 years. Some patients had history of previous TB treatment, intake of immunosuppressive drugs, and trauma on affected joints. Comorbidities including hypertension, DM, and other rheumatologic disorders were also present. Chronic monoarthritis was the most common presentation. However, acute arthritis was also observed in some patients, especially among those aged 50 and above and those with concomitant rheumatologic diseases such as SLE and aseptic arthritis. 8 patients also presented with oligo and polyarticular involvement. The mean duration between onset of symptoms and consult was almost 21 months, and this delay in the diagnosis may be attributed to the chronic and indolent nature of the disease and/or our patients' poor health-seeking behavior. Compatible with studies done in Thailand and the Netherlands, the most commonly involved joints are the weight-bearing joints, the knees, and the hips. However, we also observe that it may also affect atypical areas like the small joints of the hands, elbows, and shoulders. Majority presented with local symptoms such as limitation in ROM and soft tissue swelling. However, abscess and sinus tract formation may also be present, especially among those with chronic arthritis. Systemic manifestations like fever and weight loss were not common. The most common initial diagnosis upon admission was septic arthritis. However, concomitant septic arthritis was only documented in 10 patients. Septic arthritis should always be ruled out first in any inflamed joint, but we must also remember that TB arthritis can present acutely or chronically and should always be part of the differential. Since the management of TB arthritis and septic arthritis is entirely different, every attempt to determine the etiology of the acutely or chronically inflamed joint should be made. In this study, more than half of the patients were diagnosed based on a positive AFB smear, positive biopsy findings, or a positive PCR. CBC and inflammatory markers may also be useful. Anemia, predominantly normocytic, normochromic, and elevated inflammatory markers were frequent findings, and they reflect ongoing joint inflammation. Imaging of all the affected joints should also be done. The most common radiographic findings on X-ray were joint space narrowing, soft tissue swelling, and erosions. Majority of our patients presented with significant joint damage on admission, requiring surgical interventions such as the BRIDMA and orthotomy. Hospital stay was also prolonged with an average of 24 days, and it's likely from delayed diagnosis and initiation of treatment and recovery from surgery. In conclusion, this is the largest cohort of TB arthritis patients reported in the Philippines. There should be a high index of suspicion for TB arthritis, especially among patients in endemic countries such as the Philippines, presenting with chronic monoarthritis involving the weight-bearing joints. Prompt initiation of anticox must be done once a diagnosis of TB arthritis is established to prevent joint damage and functional disability. And lastly, surgery may also be necessary, especially among patients already presenting with significant joint destruction. Thank you and have a nice day.
Thank you, Dr. Poblete. May we now call on our judges again to give questions or comments to our presenter.
Thank you, Dr. Poblete. It's me again. Okay, I just want to say again that this is a good study, and especially since you, because it's one of my questions, but you already presented that this is the largest cohort. So I assume that this is this can also serve as the baseline research for our country, no? So with that, I think is more of relating to the patients now. So when they when they complain, is it arthritis first? No? So the tendency is to go to another specialist rather than an infectious disease doctor. Is that
ma'am? Yes, ma'am.
Okay, so this could also be this would have contributed also to the delay in the diagnosis, because they will be managed according, well, it's not part of the protocol for them to test TB for TB, right?
Yes, ma'am.
So, it's necessary to form a multidisciplinary team for the management of conditions like this? And if there is already existing in our country, are there any current treatment guidelines for the management of this?
We do have treatment guidelines for the management of extrapulmonary TB, such as TB arthritis. However, I believe that all inflamed joints should be managed by multidisciplinary team involving an infectious disease specialist, an orthopedic surgeon, a generalist, and a rheumatologist, so that we can have a full picture of the etiology of the acutely or chronically inflamed joint.
Okay, so your recommendations then should, if this were done also, then there should be no problems in the diagnosis. Because in terms of the disability, did you get data about the DALIs caused by this TB arthritis? And what is the picture in the world if we don't have local data yet? How does this rank in terms of the burden?
Sadly, like a lot of the patients who already present with the chronically inflamed joints, there is already significant joint destruction, and a lot of them are already have impaired functional disability. That's why surgery is already recommended for a lot of them. Sadly, we don't have any data yet locally.
Okay, and then last question, what are the future directions in terms of research that will arise from your study?
Well, ideally, we want to have a huge database of all the TB arthritis patients that we see here in the Philippines, because I'm sure we know we have a lot. We also want to determine what are the predictors of outcomes for TB arthritis, such as, say, functional disability or mortality if present.
Thank you.
Thank you, Dr. Poblete. So that was the last of our descriptive category. We now go to our analytical category. Our first presenter is from the Philippine General Hospital with her study Awareness and Willingness Towards Pre-Exposure Prophylaxis Against HIV Infection Among Serodiscordant Couples Who Are at High Risk of HIV in a Philippine Tertiary Government Hospital Treatment Hub, a prospective study and a cross-sectional questionnaire survey, a pilot study. Let's welcome Dr. Samantha Bartol.
Good day, everyone. Presenting to you our research entitled Awareness and Willingness Towards Pre-Exposure Prophylaxis Against HIV Infection Among Serodiscordant Couples Who Are at High Risk of HIV in a Philippine Tertiary Government Hospital Treatment Hub, a prospective and cross-sectional questionnaire survey, a pilot study. Despite HIV prevention strategies which have been ongoing in our country, the HIV epidemic in the Philippines is expanding at an alarming rate. An average of 42 Filipinos are newly diagnosed with HIV per day. As of 2015, the World Health Organization has recommended pre-exposure prophylaxis, or PrEP, should be offered as part of a comprehensive prevention. Oral PrEP is FDA approved and entails providing HIV-negative individuals with oral antiretroviral medication for the prevention of HIV. PrEP is one of the most effective means of HIV prevention interventions among MSM. Although PrEP was first introduced in the Philippines in 2017, it is still not yet readily available nationwide. To facilitate the provision of PrEP, a better understanding of the potential demand and user preference is required. Also, as policy health makers begin to deal with PrEP as a mainstream prevention, financial policy issues will become important, especially in third world countries. Serodiscordant couples are a high-risk population in acquiring HIV. No local study on PrEP use among this population has been done. The primary objective of this study is to determine the awareness and willingness towards pre-exposure prophylaxis against HIV infection among serodiscordant couples. The specific objectives are as follows. The study was conducted from January to March 2020 at the Sagip Treatment Hub of the Philippine General Hospital on the HIV-negative partners of the enrolled HIV patients. The study is a pilot study composed of two phases. The first phase was a cross-sectional study wherein eligible seronegative patients were asked to answer a 15-point cross-sectional survey focusing on awareness and willingness towards PrEP. The second phase was an interventional prospective study wherein the participants were provided with PrEP taken one tablet once a day for 3 months. An HIV ELISA was performed after the first and third month of taking PrEP. An exit interview on their compliance, symptoms, sexual practices, side effects, and willingness to continue PrEP was done after the third month. The researchers were able to recruit a total of 10 participants who qualified for the study. Majority of the participants were above 30 years of age, were males, were in a heterosexual and monogamous relationship, had a monthly income of below 10,000 pesos, were college graduates, and had no history of sexually transmitted infections within the past 6 months. Only 30% of the participants were proficiently aware of PrEP despite it being available since 2017. Knowledge of PrEP either came from their partners or from an online source. Majority of the participants perceived taking PrEP as having no or minor side effects, while one participant had no idea about the risks of taking PrEP. Knowing that their partner is HIV positive, 70% of the participants claim that having sex should be as safe as possible. None of the participants have ever used PrEP, but all were willing to try the medication to protect themselves from HIV and to have a stress-free life. A physician's advice or prescription seems to play a key role for the majority of patients' willingness to use PrEP, as well as more information about the product and also its cost. One participant was not willing to personally shoulder the cost of PrEP. Only up to 1,000 pesos was acceptable for most, while two said that only up to 1,500 pesos was acceptable for them. None of the baseline characteristics significantly affected the outcome of awareness or of willingness. Due to the safety and logistic reasons brought about by the global pandemic, only one participant followed up for the third HIV test, which turned out to be negative. 8 did not physically follow up after the third month, instead had a phone exit interview. All 8 participants had a repeat HIV test after 1 month of PrEP with negative results. Majority had an overall good experience with PrEP and were willing to continue the medications, while among the 30%, 2 claimed that taking the medications were an inconvenience, while 1 was not able to take the PrEP. Most did not experience any side effects, while 20% experienced minor side effects, which included hyperacidity and pruritus. As for condom usage, 60% were unchanged, while 20% used the condom less while on PrEP. This has social implications, as PrEP does not prevent other sexually transmitted illnesses. All of the participants on PrEP maintained their monogamous relationships. Majority of the studies done on PrEP are on MSM, while only a handful of studies are on serodiscordant couples. This study found a high rate of serodiscordant heterosexual couples willing to take PrEP. Among the seronegative partners, 8 were male and 2 were female. Our country should not only focus on MSM PrEP implementation, but also on heterosexual couples as well. Facilitating factors for the use of PrEP included the advice from a physician, perception that PrEP is safe, motivation to stay HIV negative, and also to have a worry-free sex life. A barrier to the use of PrEP was the need to take medications daily. Another challenge is the cost. So a 30-tablet bottle of PrEP cost around 2,000 pesos. Majority were only willing to pay up to 1,000 pesos. Despite the small sample size, the results of this pilot study is promising. Overall, PrEP is safe and an effective strategy in the prevention of HIV. Socio-demographic parameters did not affect PrEP awareness or willingness. Several challenges in the implementation of PrEP in the Philippines is due to a lack of awareness and understanding of PrEP as well as its affordability. Serodiscordant couples are an understudied population who represent a high priority group for PrEP implementation. Despite the challenges, the Filipino people should be made aware of this treatment strategy. Thank you.
Thank you, Dr. Bartolo. May we now call on our judges?
Thank you very much, Dr. Bartolo, for that very interesting and very public health related study. I'm happy that you embarked on this study and you did this while we were having the pandemic. Anyway, I would also like to commend your paper because you clearly stipulated there, or you clearly stated the ethical considerations, what we were actually looking for. And then my question is first, the questionnaires, were they formulated by your group or was it based on some previous studies?
Good afternoon po, ma'am, and everyone. So the questionnaire po was mainly based on a study done in Berlin on MSM. And then we tailor-fitted the questionnaire to our demographics po, to the Philippine setting. And then it was translated po to Filipino by and back translated to English. And then we had a trial run po on some HIV patients and also some on HIV patients po to see if they could understand the questionnaire.
So the questionnaire was self-administered, right? So there was no interview that occurred except for the exit interview.
Yes po, ma'am.
Okay. Because in your paper, the one that was written or written there or included was the English version. Did you do it using the English version or the Filipino version?
The participants, ma'am, were made to choose po which was more comfortable for them.
Okay. And then who was the one who administered the questionnaire? Was it the medical practitioner or the nurse or the staff in Sagip?
Me po, ma'am, personally.
Okay. Okay, thank you very much. And then with regard to the recruitment of participants, I'm sorry I may have missed reading that or hearing that from your presentation, but how were your 10 participants recruited?
They were recruited, ma'am, when a newly diagnosed HIV patient would enroll in our SAGIP. I instructed the head nurse, ma'am, to inform me, and then I would ask them po if their partner would be willing. So on their next follow-up, ma'am, if they were willing, they could bring their partner so we could explain po the study.
But and then when the partners agreed, when the partners went with the patient, you again got their consent.
Yes, ma'am.
Okay, and then because you only had 10 participants, of course, because it's pandemic. But are you going to continue this study?
Yes, ma'am. I actually endorsed the study. So to become a full-blown study, ma'am, not just a pilot study.
Okay. Because we would also want to hear the results when there are more participants. So thank you very much.
Thank you din po.
Thank you very much, Dr. Bartolo. Our next presenter is from Makati Medical Center with her paper Risk Factors for the Development of Bloodstream Infection from Urinary Tract Infection Caused by Extended Spectrum Beta-lactamase Producing Escherichia coli and Klebsiella pneumoniae. May we now call on Dr. Christine Jane Hermo.
Good day, everyone. First of all, thank you, PSMID, for giving me this once-in-a-lifetime opportunity, and I am humbled and honored to be chosen to present. My name is Christine Jane Hermo, and I will be presenting my research entitled Risk Factors for the Development of Bloodstream Infection from Urinary Tract Infection Caused by Extended Spectrum Beta-lactamase Producing E. coli and Klebsiella pneumoniae. E. coli and Klebsiella pneumoniae are major nosocomial pathogens causing infection. It causes UTI, pneumonia, bacteremia, and intra-abdominal infection. These organisms had been uniformly susceptible to antibiotics. However, during the past 2 decades, because of massive inappropriate antibiotic use, resistant organisms have emerged, and one of those is the antibiotic-resistant strain that produced extended spectrum beta-lactamases, or ESBL. ESBL is one of the most important emerging resistant mechanisms that threatens antimicrobial use. Bacteremia from these organisms increases morbidity and mortality, and it's a treatment dilemma because of limited antibiotic for the treatment of this organism. It has been demonstrated that ESBL production by these infecting organisms adversely affects the clinical outcome. It is therefore imperative to identify risk factors, to quantify the problem, reinforce prevention, and promote proper practice and initiation of appropriate antibiotics. This study determined risk factors in developing bloodstream infection from UTI caused by ESBL E. coli, and Klebsiella pneumoniae at Makati Medical Center. Demographic profile were analyzed and determined. This is a retrospective cohort study conducted at Makati Medical Center, which is a tertiary hospital in the Greater Manila area. Medical records from January 2016 to December 2018 were collected and reviewed. Consecutive patients who are 18 years old and above who had urine isolates of Klebsiella pneumoniae and E. coli with blood culture results were concluded in the study. The student C-test and special exact test were used to compare continuous and categorical variables respectively. In identifying the independent risk factors, a backward stepwise logistic regression analysis was used. Multiple logistic regression analysis using 95% level of significance was used to determine the independent association of different risk factors. During the study period, 1,590 patients had urine isolates which grew E. coli and Klebsiella pneumoniae. Of this, 27% had ESBL producing E. coli and Klebsiella. 81 patients had both urine and blood culture specimen, and of this, 38% had bloodstream infection. Table 1 is the demographic characteristics of the patient. Patients with bloodstream infection, the age ranges from 19 to 97, and those with no BSI ranges from 27 to 99. More than 60% of patients with BSI were above 6 years old. As compared to the paper done by Colodner et al., they found out the same result, where in patients with age over 6 years old are more at risk in the development of BSI from UTI. Sex characteristics reveal that males, 1/3 of patients with BSI were males, while patients with no BSI were mostly females. So this is also consistent with the study done by Raz et al. In 2000. They mentioned in their paper that the main reason for the sex and age effect is that maybe the elderly males develop complicated UTI more frequently than elderly females. Infections with BSI were mostly community acquired. In terms of immunocompromising conditions, in terms of underlying illness, both BSI and without BSI recorded hypertension as the highest number of cases, with 67.7 and 74% respectively. In terms of immunocompromising conditions, diabetes mellitus has the most number of cases for both PSI and no BSI. And also important in this table is, as you can see, prior hospitalization. Almost 2/3 of the patients with PSI had history of prior hospitalization, with 71%. Table 2 is the prevalence for each of the bacteria. So here in this table, E. coli, ESBL is the highest causative organisms for both BSI and those without BSI. So Klebsiella pneumoniae prevalence is lower compared to E. coli. So table 3 shows that at 95% level of significance, those with underlying nervous system disease and those with prior use of antibiotics were highly associated with development of bloodstream infection. However, after controlling for other predictor variables in the model, the results showed that age, sex, and prior hospitalization are only the independent risk factors highly associated with the development of bloodstream infection from UTI caused by ESBL producing E. coli and Klebsiella pneumoniae. It can be noted from the results that the lower the age of the patients, the less rate is to develop BSI, and the higher the age, the higher it is to acquire BSI. On the other hand, males were more at risk to having BSI than females by almost 9 times, and prior hospitalization also increases the risk of having BSI by almost 12 times. To my knowledge, this is the first research in the Philippines to look at the risk factors associated with the development of bloodstream infection from ESBL producing E. coli and Klebsiella pneumoniae from urinary tract infection. Results showed that age 6 years old and above, being male, and patients who had prior hospitalization are significant predictors for the development of BSI among patients with complicated UTI. This may be an important aspect of the clinical management of the infection, and this study provides an important information on the characteristic of the target population that might help determine infection control measures and initiation of treatment options. Although clinicians need to be aware of the situation, international public health control measures and antibiotic stewardship are needed to prevent the further spread of this organism. Thank you.
Thank you, Dr. Hermo. May we now call on our judges for your comments, questions?
Hi, good afternoon, Doctora. Thank you for that presentation. I'm Rosario Reyes. So, I just noticed that you mentioned in your conclusion and also in your paper that there is highly significant in the age and gender, right?
Yes, madam.
As a risk factor. However, if you would notice that the confidence interval is very wide,
Yes.
so I would be careful in making conclusions if the confidence interval is very wide because it usually would indicate low level of precision. So yeah, so that's just my comment. With regard to my question, I only have one question. What is it in the prior hospitalization that makes it a risk factor for the development of bloodstream infection from UTI?
Usually the patients who were previously hospitalized were exposed to antibiotics. So they are immunocompromised, exposed to previous antibiotics, so they are more prone to develop if they get another infection, they're more prone to have a resistant organism. That's why it's very significant to include that in the risk factors.
Okay. So it would be good if you include that information in your paper, and if you would include also data based on your result that would support that, like how many patients among those with prior hospitalizations have received the antibiotics and sort of like that.
Okay.
Okay. Thank you.
Thank you. Our next presenter is from San Lazaro Hospital with her paper entitled Early Predictors of Severe Dengue Derived from the WHO 2009 Guidelines Among Adult Dengue Patients Admitted at the National Tertiary Infectious Hospital. Please welcome Ms. Dr. Myvi P. Galon.
Good day, I am Myvi Galon and I will be presenting my research entitled Early Predictors of Severe Dengue Derived from the WHO 2009 Guidelines Among Adult Dengue Patients Admitted at the National Tertiary Infectious Hospital. Dengue is still an endemic arboviral disease causing breakthrough epidemics, especially in our country for the past years. Despite collective efforts from us clinicians and from the Department of Health, morbidity and mortality continuously increases. Other countries in Southeast Asia have already published several articles on the development of predictive tools for dengue severe. However, a predictive tool based on our local data will help us to identify which subset of patients that will most likely progress into severe dengue. It will be of great contribution to the improvement in the outcome of dengue in our country. These are the specific objectives of the study. This is a prospective cohort study of adult dengue patients admitted within the first 5 days of illness for the year 2019. After obtaining consent, each participant was interviewed as to the presence of signs and symptoms for dengue based on the 2009 WHO guidelines. Baseline laboratory results were then noted. Confirmation of dengue was done by noting serologic tests results, especially your dengue NS1. Each of the participants was followed up until the 6th day of illness with the primary endpoint of progressing into severe dengue or not. Odds ratio and the corresponding 95% confidence intervals were computed to determine the association between clinical profile and severity of dengue. PERT logistic regression was used for the multivariate analysis of crude and adjusted odds ratio to create a scoring system for the predictors of severe dengue. Yoden's index was used to determine the cutoff point for the scoring system. Five-fold cross-validation and receiver of curve analysis were used to determine the performance of this prognostic tool. 569 patients were included from the 1,151 admitted adult dengue cases, of which 47 progressed into dengue severe during the observation period, thus giving us a prevalence rate of 8.6%. For this study, the most frequent day that the patient went into dengue severe was on the 5th day of illness. This table shows the baseline characteristics of all participants wherein these factors were noted to be independently associated with the development of dengue severe. Female, obese, previous dengue infection, diarrhea, tachycardia, platelet count of less than 50,000, increased liver enzymes, elevated creatinine, low albumin, and positive dengue NS1. Regression analysis was done from the adjusted crude odds ratio. Stepwise selection was done with 5 predictors identified since there were only noted 47 events or dengue severe. As a rule of thumb, there should be at least 10 events for every predictor. Hence, the following variables were included in the final prediction model for dengue severe: gender, previous dengue infection, presence of diarrhea, AST, albumin, plus addition of a constant value of 2. The optimal cutoff for this prognostic tool was determined to be at 2. Receiver operator curve analysis was done showing that at this cutoff, the area under the curve is low at 0.85. By using this predictive tool, during the first 5 days of illness, a score of 2 or higher will have 77% probability that the patient will progress into dengue severe, translating to a more aggressive management and better clinical outcome. This prognostic tool has only been internally validated. Hence, we recommend to apply this on dengue patients admitted during the early course of the disease in order to determine its actual performance. In conclusion, the prevalence rate of dengue severe in our institution is 8.6%. The clinical and laboratory parameters significantly associated with dengue severe were the same with other studies reported. After multivariate analysis, the following variables were included in the prediction model for severe dengue: gender, previous dengue infection, presence of diarrhea, AST, albumin, plus addition of a constant value of 2. A computed score of 2 or higher has the optimal discriminative power to determine if a patient will go into severe dengue. The sensitivity of the scoring tool is 77%, while its specificity is 79%. These are my references. Thank you.
Thank you, Dr. Agalon. Judges, Dr. Agalon is ready for you.
Thank you, Dr. Galon. It's a very good study with the rich public health implication, and also very relevant given that we are now also experiencing the surge in dengue cases aside from the pandemic we are battling. Okay, so my question is, you mentioned that there were already prognostic tools developed in the region, like in Southeast Asia. Why was the decision why did you decide to develop a new one rather than adapt existing tools and then validate this in the local setting? I know you mentioned that it's because you want it to test using our local data. But for research purposes, sometimes we also discourage reinventing the wheel when there are already existing methods that can be reproduced. But perhaps you have other factors that you took into consideration. Can you share with us?
Afternoon, everyone. Basically, the literature in Southeast Asian, the predictive tools consist of different populations. So, the one that presented in Vietnam consisted of pediatric population and outpatient setting, while the other is a mixture of pedia and adult setting. So, when I did literature search in the Philippines, unfortunately, I wasn't able to come up with somehow a predictive tool or a research that is similar. So that's why I opted to start from scratch from our own data in adult patients so that I will be able to somehow um, create a tool that will be helpful in predicting severe dengue.
Okay, very nice. So maybe that is something that you need to highlight in your paper also, because you can claim that this is the first in the Philippines for use among adult patients. Okay, so thank you. Very good. And then my next question is, I just want to understand, because from your crude analysis, no, from the crude associations, there were already variables that were associated with your outcome. But in the multivariate analysis, you use no, or you chose you included different variables. Usually, the decision is what you found significant in the crude analysis is what you include in the multivariate one. So why was this done? Could you specify the modeling that you did for the final tool?
Well, actually, from the different parameters, mostly the parameters identified already established that it is really related to dengue severe, except for the albumin, which is not yet really established. So, what we did, since there were only 47 patients who underwent dengue severe, we chose the one that statistically the p-value that is lesser 0.5, and then from there we were only able to come up with five statistically significant parameters that is also clinically and easy to adopt. So the gender, the previous dengue infection, it's easily being asked, while the history of diarrhea, it's also simple, except for the two laboratory, the AST and the albumin, that needs laboratory results. So it's a combination of clinical and statistically significant parameters. So that's where we're able to come up with the five parameters. So that we.
Thank you, Dr. Galon.
Thank you.
We're down to the last two papers for our research presentation. We now proceed to the paper from Cardinal Santos Medical Center to be presented by Dr. Charlene A. Dizon, entitled Clinical Outcome of Tocilizumab Administration on COVID-19 Patients with Cytokine Release Syndrome and Acute Respiratory Distress Syndrome, a retrospective cohort descriptive study. We're just having some technical difficulties, but we'll be proceeding to the next paper. Okay, our next presenter is from Makati Medical Center with her paper entitled Predictors of Mortality in Patients with Staphylococcus aureus Bacteremia. Let's welcome Dr. Erica Caperonce.
Good afternoon. On behalf of my co-author, I would like to present my paper entitled Predictors of Mortality in Patients with Staph aureus Bacteremia. SAB has very high mortality rates. Some of observational studies have aimed. Good afternoon. On behalf of my co-author, I would like to present my paper entitled Predictors of Mortality in Patients with Staph aureus Bacteremia. SAB has very high mortality rates. Some of observational studies have aimed to analyze predictors of mortality, but the results are varied. Some studies, on the other hand, have tried to identify factors and management practices that improve outcomes instead. But in the local setting, SAB characterization has not yet been done, and we believe there is merit in doing this. Our primary objective was to identify predictors of mortality in patients with SAB admitted in a tertiary hospital, and we also wanted to describe patient characteristics, assess physician management and practices, and determine inpatient mortality. We conducted a retrospective study over a 7-year period and included all adults with at least one clinically significant positive blood culture showing Staph aureus registered in the MMC IPC HONIT. The patients with polymicrobial cultures refused management, had inaccessible records, or incomplete charts were excluded. This is the overall flow of our study. So we compared the factors against those who survived and those who expired in order to determine factors affecting mortality. This is just to show you the details of the patient characteristics that we investigated. So we also noted their condition at diagnosis and also pathogen factors such as MRSA and whether it was community or hospital acquired SAB. So we also, as per indicated by the physician, we also noted the source of SAB, and we also noted if there was a drainable focus or an infected catheter and whether or not these were removed. So in order to assess physician practice, the following quality indicators of management were noted, and we define adequate empirical coverage as follows. So we also noted if the targeted antibiotic, which is the prescribed antibiotic after susceptibility of staph was already known, if it was appropriate or not using the following regimen for MSSA and MRSA. So we also noted time zero, which is the time that Staph aureus bacteremia was first documented, either in the chart or the time of release of the gram stain of the blood culture result. So we also noted the timing of antibiotics as in relation to time zero, so as indicated in the medication administration record, the timing of source control, and the timing of ID referral. So our main outcome was inpatient mortality. So we used the following statistics for our study. So overall, we had 132 positive SAO blood cultures from HONIT. We excluded 32 for the following reason. So overall, we had 100 patients included. So for the general profile of our SAB patients, the median age was 57, majority were male, 46% of the isolates were due to MRSA, and 81% were community-acquired bacteremias. Most common source of SAB was skin soft tissue infection, and 15 out of 100 had line-related infection. 93 of them had the infected catheter removed within the same day of SAB diagnosis. In those who had a drainable focus, the median time to source control was 3 days. Most of our patients had antibiotics upon ER admission. 85% received antibiotics prior to SAB, and in 72%, the empiric coverage was adequate for the staph isolate. 79%, the shifted targeted regimen was appropriate. Most patients had a referral to IDS service. A 2D echo was requested in 67%. Surveillance blood cultures were done for 72%. And in 66%, the type of SAB, whether complicated or uncomplicated, was determined. So the overall mortality rate was 23%, and seen here in the Kaplan-Meier, most of the events happened during the first 7 days. In fact, 13 out of 23 expired within the first 7 days of admission. So on crude analysis, the factors associated with mortality include heart failure, septic shock, respiratory failure at diagnosis, as well as having no identifiable focus for SAB and the need for ICU transfer. The following in blue, survivors were more likely to have a drainable focus, source control, IE ruled out, the type of SAB determined, and had surveillance blood cultures requested. So for the independent predictors of mortality, among patients with SAB, heart failure and respiratory failure at diagnosis were seen to be independent predictors. SAB and heart failure patients had 25 times more likely are 25 times more likely to die compared to those without, and patients with SAB and respiratory failure were 30 times more likely to die compared to those without respiratory failure. So doing surveillance blood cultures reduces the odds of mortality by 84%. So in this study, we've observed an overall hospital mortality rate for SAB that is similar to other studies, and the fact that they die early highlights the impact of this disease. So there are limited limited data on respiratory failure and mortality in SAB, and we were able to see that those with respiratory failure are 3.5 times more likely to die. So heart failure was found to be an independent predictor of mortality. So this is also similar to the findings in a large Danish study. So in contrast, we were not able to see a difference with these factors. And we also noted that doing surveillance blood culture significantly reduces the odds of mortality by approximately 85%. So documenting bacteriologic clearance guides duration of treatment and identifies the need to pursue investigation for metastatic complications of SAB. So there is an opportunity to improve in our setting because only 72% of our patients had surveillance blood cultures done. So these findings may be used to guide the creation of SAB care bundles. So we had a smaller population. However, we tried to maximize our data by including all. And compared to other similarly designed studies, we had very extensive documentation of their clinical profiles. So there is role for future studies, of course. So our conclusion is in patients with heart failure and respiratory failure, they will benefit from more aggressive management of SAB as these have been found to be independent predictors of mortality. Doing surveillance blood cultures are recommended. Adhering to that guideline recommendation is recommended because they have been found to significantly improve outcomes. Thank you very much.
Thank you, Dr. Caperonce, for that presentation. You may now face our quizzes.
Good afternoon, everybody.
Good afternoon, Dr. Caperonce. Thank you very much for your very interesting research. My question is, first, because you emphasized several times in your paper and also in your presentation that doing surveillance blood culture significantly reduces the odds of mortality. May I ask at what points should the surveillance be done, especially when the patient is hospitalized?
Actually, Doctor, there is already an existing it's guideline that recommends doing blood cultures 2 to 4 days after the first documentation of bacteremia.
Okay. And then
I'm sorry, Doctor, if my video is glitching.
It's okay. You've also mentioned that your confirmation for the presence of the organism of Staphylococcus aureus was based on gram staining only. So you did not use other laboratory of other means of identifying the organism.
I'd like to clarify, Doctor, that gram stain was used in order to determine just the timing of diagnosis of Staph aureus bacteremia, but our
Mhm.
actual we actually had blood cultures with full sensitivity results po, doctor, after the gram stain results po.
Okay. Because maybe I have misunderstood what you've written in your paper. So thank you very much for the clarification. And then my last question is on the use of the catheters. Did you also take or consider the length of time? Although I think you did not do this in your study, the length of time by which the catheters were used by the patients.
No, doctor. That's a good point, doctor. No, I was not able to note the duration po of the catheter use.
What are you planning to do studies like this?
I think, doctor, it would involve another objective.
Mhm.
So we will look into it, doctor, because the primary reason why we went into this study is because we really wanted to see the current practice in our hospital so that we can also improve our treatment management.
But I'm also surprised that MRSA was not associated with the outcome of your patients. Why do you think
Yes.
so?
According to literature, doctor, there's also varying results regarding the association of MRSA. Although it's plausible, it's more plausible that it is a more severe version. But also in the previous studies that I have looked into, doctor, the results also vary po.
Okay, thank you very much.
Thank you po, doctor.
Thank you very much, Dr. Caperonce, for that very interesting study. We're down to the last presentation from Cardinal Santos Medical. I'm sorry. Yeah, from Cardinal Santos Medical Center. May we now call on Dr. Charlene A. Dizon for her paper, Clinical Outcome of Tocilizumab Administration on COVID-19 Patients with Cytokine Release Syndrome and Acute Respiratory Distress Syndrome, a retrospective cohort descriptive study. Dr. Dizon.
Good day, everyone. I'm Dr. Charlene Dizon, and I'm here to present our research paper entitled Clinical Outcome of Tocilizumab Administration on COVID-19 Patients with Cytokine Release Syndrome and Acute Respiratory Distress Syndrome, a retrospective cohort descriptive study. The novel coronavirus that originated from Wuhan has spread worldwide and became a pandemic. COVID-19 infection may present variably, and the most frequently reported initial symptoms include fever, cough, and dyspnea. For critically ill COVID-19 patients, there was found to have increased concentration of pro-inflammatory cytokines characteristic of cytokine release syndrome, which has been linked with cardiovascular collapse and multi-organ failure. Interleukin 6 was identified as a marker most involved in aggravating severe COVID-19. Tocilizumab is an IL-6 receptor antagonist, which may reduce inflammatory activity and acute phase response. Multiple studies conducted abroad showed that patients given tocilizumab had clinical improvement with less days of hospitalization and mechanical ventilation requirements. This study aims to describe the clinical outcomes of tocilizumab administration in COVID-19 patients with CRS and ARDS, specifically the inflammatory markers, oxygen requirement, days of hospital stay, vasopressor requirement, and mortality. This is a retrospective cohort descriptive study, and the study population was obtained by purposive sampling, wherein patients who are confirmed positive for COVID-19 via RT-PCR admitted at Cardinal Santos Medical Center from February to August 2020 were selected. Part of the inclusion criteria was the presence of ARDS and CRS. Those patients who have not yet been discharged from at the time of conclusion of the study were excluded, and the patients with contraindications to tocilizumab administration were instead included in the control group. Data was gathered from the record section through chart review. A total of 69 patients were selected and grouped into two. 43 of them received 8 mg per kilogram of tocilizumab via IV infusion, and the remaining 26 patients in the control group were given standard therapy. Statistical analysis was done and the level of significance was set at 5. The baseline clinical characteristics of the patients in the two groups were tabulated and summarized. The mean age of both study groups was not statistical. There were more males than females in both groups. The most common comorbidity observed was hypertension. Other cardiac diseases include coronary artery disease, heart failure, and cardiac arrest. There was no significant difference between both groups for their smoking. The most common initial symptom observed was fever. Here is the summary table of what have been discussed earlier. Most did not have pertinent travel history, but a few had exposure to known COVID confirmed cases, such as from a family member or at the workplace. Initial chest radiologic findings all showed pneumonia, mostly bilateral infiltrates rather than one-sided. PF ratio and inflammatory markers were obtained for comparison and analysis. This table shows the mean values with two standard deviations of the results, which were taken from baseline workup for the control group and from the latest workup prior to the dose of tocilizumab for the treatment group. This table shows the same tests but taken days 2 to 4 post-tocilizumab or days 4 to 8 from the baseline for the control group. In this table, the values shown are the change from the baseline. In this graph, the blue line represents the control group while the red line for tocilizumab group. The PF ratio had improved for the control group while there was a slight decline for the tocilizumab group. An inverse graph was seen in LDH wherein the tocilizumab group showed increased levels. For both groups, the CRP levels had decreased, as well as for ferritin. However, all of these still had no statistically significant difference, most likely because of the presence of multiple confounding. As seen in this table, most of the patients in this study received more therapeutic arms in the tocilizumab group. Both groups had patients who required vasopressors. All patients required oxygen support, but those in the control group required more days on invasive mechanical ventilator. Similar percentage of patients were admitted at the ICU. The mean hospital stay was at 18 days for both groups. Lastly, the mortality rate was higher in the tocilizumab group despite more treatment measures were given. To summarize, there was no statistically significant difference on the outcomes between the two. Interleukin-6 levels has a role in inflammatory storm but was not included in the study because it was not readily available at the institution. As a result of this study, the administration of tocilizumab did not have significant effect in clinical improvement of severe COVID-19 cases. One of the ongoing RCTs, namely Corimuno-Toci trial, is anticipating beneficial effect of tocilizumab compared with standard of care. Adverse events from other studies include urti, headache, nasopharyngitis, and GI events. From this study, there were 4 patients who developed lower GI bleeding during the hospital stay after tocilizumab administration. However, no further workup or investigation. In conclusion, severe COVID-19 patients who developed ARDS and CRS given tocilizumab had no significant difference in the clinical outcome to those who did not receive tocilizumab. Limitations of our study include small sample size, difference in the baseline laboratory findings, and days of follow-up and multiple treatment modalities used on the patient. Our recommendation for future studies is to conduct a multi-center study in order to increase study population, and the preferable research design would be an RC. These are our references. Thank you for listening.
Thank you, Dr. Dizon. Judges?
Yes. Hello, good afternoon again. Thank you, Dr. for that presentation. Your study is very relevant today in this time of COVID-19. I only have 2 questions. So first is that I'm interested to know if you ever considered including the timing of treatment initiation as well as severity of comorbidity in your paper, because because I think there could have been, when I read other studies, they mentioned also about these factors and its impact on on the results of the study. So what do you think? Would have impacted the results as well of your study if you look at that, at those factors?
Sorry po, Doctor. We didn't get the question because the internet was choppy.
Okay, I'm asking if you have looked into the impact of the timing of treatment initiation as well as the severity of the comorbidity, if you factor those in your analysis.
Uh, yes po, Doctor. Actually, for the timing of the giving of tocilizumab, it was included in the chart review when we reviewed the medical records. However, we weren't able to do statistical analysis on the specific data po.
Okay, but I think it would be good
Yes po.
if you're going to include that because it would have it would offer more information and understanding on the result of your study. Especially, you mentioned that as compared to other studies, they found out that the tolizumab showed clinical improvement after giving this to the patient. So my second question is, what do you think the factors that could have underestimated the magnitude of the beneficial effect of tocilizumab in your study?
In our study, I think the presence also of other treatment arms given to the patients played a major factor for
For the
the
effect of the tocilizumab on our study control group.
So again, it would be good if you include that since you already
Okay, so
mentioned of the difference of the findings from other studies.
thank you.
Thank you.
Thank you very much. So
Thank you
that
po,
was
Doc.
our last presenter. So our judges will now go to our breakout room to uh, to compute the scores and announce the winners later. In the meantime, I would like to invite every one of you to stay with us up to day 5 of our convention. For tomorrow, we still have several plenary sessions. PSMID COVID Chronicles, the stories from the front lines at 2 p.m. in the afternoon, followed by the Dr. Elpidio Gamboa Memorial Lecture, PSMID and the History of ID in the Philippines, the Dr. Bienvenido Alora Memorial Lecture, Shaping the ID Leaders of Tomorrow. And of course, for our members tomorrow night, it's our gala night with the theme, Timeless 50 Years of Unparalleled Excellence. Again, we would like to congratulate all our presenters for enriching our knowledge. So even if we are in the time of COVID, we have papers from varying aspects of infectious diseases like HIV, vaccination, tuberculosis, and multi-drug resistant organisms. I think we have prepared a short video presentation of our fellows' activities for the past year. Pleasant afternoon again. Are the judges ready for their decisions?
Okay, good afternoon, doctors. Good afternoon, Dr. Ferdy. On behalf of, so I have the pleasure to announce the winners for today's research competition. But before I announce, first I would like to congratulate all the presenters for the good research studies that will really improve further the clinical and public health picture in our country. So continue upholding research and for the pursuit of knowledge and for the improvement of the health of all Filipinos. Okay, so first we'll announce the winners for the descriptive category. Drum roll, please. Okay, so third place goes to the research titled Genetic Diversity of Mycobacterium tuberculosis Isolates from a Rural Community in the Philippines. Congratulations.
Congratulations. I think that's from Philippine General Hospital, Dr. Jonel B. Poblet.
Okay, so I proceed. Congratulations. Now, the second place goes to the research team of the study entitled Clinical Profile and Outcomes of Patients with Tuberculous Arthritis Admitted in a Tertiary Hospital in the Philippines. So I think it's a double win for Dr. Poblete. Congratulations.
Congratulations, Dr. Poblete, for your second win.
And the first place goes to the study entitled Presenting Characteristics, Comorbidities, and Predictors of Mortality Among 236 Patients with COVID-19.
Congratulations to Dr. Christy Michelle Taladua and the team from Makati Medical Center for being the first prize winner of our descriptive category.
Thank you, Dr. Ferdy, and congratulations to all the winners.
Congratulations.
So now announce the winners for the analytical category. So the third place goes to the study entitled Clinical Outcome of Tocilizumab Administration on COVID-19 Patients with Cytokine Release Syndrome and Acute Respiratory Distress Syndrome, a retrospective cohort descriptive study.
Congratulations, Dr.
Congratulations. Thank you for mentioning their names, Doctor. I only have the titles in the list, so thank you. Congratulations. Now, the second place goes to the study entitled Predictors of Mortality in Patients with Staphylococcus aureus Bacteremia.
Congratulations, Dr. Erica Caperose from Makati Medical Center.
Okay, and the first place goes to the study done by the team of, so the study title is Early Predictors of Severe Dengue Derived from the WHO 2009 Guidelines Among Adult Dengue Patients Admitted at the National Tertiary Infectious Hospital. So I think this is from San Lazaro Hospital. Congratulations.
Congratulations, Dr. Maidi P. Galon from San Lazaro Hospital. So there goes our winners I would like to thank again our judges, Dr. Sharon Villanueva, Ms. Rosary Ann Reyes, and Dr. Paul Jean Claro for gracing our annual Antonio Gonzaga Memorial Research Forum. And to conclude our program, we now call on the chair of the research committee, Dr. Maricel Gler.
Thank you so much to everyone for participating in our 2020 first virtual research forum. And I would like to thank all the judges, the MCs, everyone who attended. Of course, for the authors, this is not the end of your paper's journey. No, you have to publish, and that's what's most important. So publish, publish, publish. And if you're an IB fellow, you can have a publication assistance from PSMID. Thank you, everyone.